Hi everyone, this is Izzy. I'm one of the F1 leads at Mind the Bleep. Today we've got our social media lead, Sanojha, doing the talk. So without further ado, I'm going to hand over to Sanojha to crack on. Thanks very much.
Okay, so hi everyone, thank you for joining us today. Today we'll be covering endocrine and metabolic emergencies, and this will include diabetic ketoacidosis, hyperosmolar hyperglycemic state, adrenal crisis, and hypoglycemia. In terms of our aims, we want to recognize emergencies early on, start immediate management safely, and know when and how to escalate. And endocrine and metabolic emergencies are quite common on-call and night shift presentations, and they can be quite high risk, but are fairly treatable if you recognize them early. And as an FY1 or FY2, we are often the first person to assess the situation. And this situation will be quite easy to understand once you get the hang of the flow and the algorithms. And this session will be quite a practical one. I'll emphasize all the key points that we should know and the management steps that we would expect you to know at a foundation level. And we'll have a few practical case studies with some questions so you guys can see how well you've understood the information that's been taught to you. And if you have any questions, feel free to drop it in the chat, and either me or Izzy will have a look and try to answer. So in terms of general principles, as always, you must always do an ABCDE assessment of the patient. And if you're getting a bleep from a nurse, for example, or another healthcare professional about a patient, try to ask for them to do the initial ABCDE assessment so you can get all their vital signs. You should check the capillary glucose early on, and as always, take a focused patient history and examination once you see the patient. And in terms of what I would like to do before I see a patient, I tend to, instead of immediately seeing the patient and then finding out all the information, I try to get their notes either on a computer system or written notes, depending on how your hospital works, just to get a clearer image of what you want to do rather than facing the situation head on with any confusion. As in that scenario where you've looked at the notes beforehand, you can review the medications that the patients had and any recent illnesses that could be precipitating the scenario. And as always, when you're confused or you think that the scenario is quite specifically concerning to you, you should escalate early to either the medical registrar or ICU if you feel it's necessary. And these endocrine emergencies often present with very non-specific symptoms, and you should always treat the capillary glucose level as a vital sign, as that can be a very easy way to identify if the blood glucose levels are responsible for this. And another important thing I want to highlight is that you should always escalate to a senior if you're concerned, as nobody expects you as a foundation doctor to manage these scenarios on your own. But just to do the above steps of initially assessing the patient, taking a focus history, and reviewing any potential causes that can be fixed there on the spot. And now we'll first talk about DKA in a bit more detail. So DKA is due to an absolute or relative insulin deficiency, and it's commonly triggered by either infection or missed insulin doses. And reduced insulin action causes decreased glucose uptake and increased hepatic glucose production. That leads to the hypoglycemia. And then this excess glucose results in osmotic diuresis. That leads to the dehydration and the electrolyte loss. And as the cells are unable to use the glucose, the body increases its fat breakdown, and that produces the ketone bodies in the liver. And then the ketone accumulation is what leads to the high anion gap metabolic acidosis. And then, although the total body potassium is depleted, serum potassium in the patient might be normal or raised, and that metabolic acidosis stimulates this deep, labored breathing that we'd call Kussmaul respiration. And here on this slide, I've included the common triggers that you should be aware of or keep in the back of your head. That would include infections, a missed insulin dose, a new diagnosis of type 1 diabetes in a patient, MI, stroke, or surgery. And we diagnose DKA if all three criteria are met. So these three criteria would include hyperglycemia, so blood glucose over 11 millimoles per liter, of the patients are known diabetic already. Ketonemia, so a blood ketone level of over at least 3 millimoles per liter or more, or urine positive ketones. And then the final parameter is metabolic acidosis, a pH that is less than 7.3, or a bicarbonate level less than 15 millimoles per liter. And it's important to look at the blood ketones rather than the urinary ketones if possible. And a lot of foundation year doctors, they forget that the bicarbonate or pH is part of the criteria for DKA. They seem to fixate on the ketonemia levels. And the reason why we should remember the ketone levels is that that differentiates DKA from just a patient having hyperglycemia on its own. And in terms of our initial assessment with the patient in DKA, so as always, we'll do an ABCDE assessment. We'll look at their vital signs, their heart rate, their blood pressure, the respiratory rate, the oxygen saturation, their temperature. We'll do a capillary glucose and look at their ketone levels. We'll also do a VBG, ABG to look at their potassium levels, to see if they're in metabolic acidosis, for example. We'll take blood, send it off for Usanese, creatinine, full blood count, CRP, to see if it's an infection, and also take blood cultures if we're suspecting sepsis in the patient. So all the regular steps we'd want a foundation doctor to do. And when you're assessing the patient, you may also see that they are dehydrated. You can supplement them with fluids. You will possibly see the Kussmaul breathing, and you'll smell the fruity odor that you'll see in ketonemia. Now, in terms of management, we prioritize fluids. So we'll start off with the fluid management, and then we'll move through each subsequent step. So we typically use 0.9% sodium chloride, and we'll adjust the volume based on the age of the patient, if the patient's in a heart failure, renal disease. These are all examples of when you would have a reduced dose compared to normal. And then our management depends if the patient is hypertensive in shock or if they're not in shock. So if they're in shock or severely hypotensive, we'll give them 0.9% sodium chloride, 500 mils intravenously over 15 minutes as a bolus, and we'll repeat it if necessary. Then we'll continuously assess the patient's perfusion, blood pressure, and urine output. And if the patient's not in shock, we'll start maintenance fluids. So that will be the 0.9% sodium chloride at a typical rate of 15 to 20 mils per kilogram during the first hour. That approximates to about 1 to 1.5 liters for an average adult. And then once the patient is hemodynamically stable, we'll continue the fluid replacement with 0.9% sodium chloride, and we'll adjust the rate of the fluid flow based on the patient's clinical status. And that, as always, includes the blood pressure, heart rate, urine output, as well as the other lab results of sodium, potassium, and glucose levels. Next, we'll move on to the management of their insulin. So we'll start a fixed rate IV insulin infusion. We'll give it at a dose of 0.1 units per kilogram per hour, and we do not give this as a bolus. This is especially important as there's no mention of bolus is used in the UK guidelines. And we continue the patient's long-acting insulin, as continuing a background insulin prevents a rebound hypoglycemia later for the patient. Then in terms of our final management of the key components of DKA, we'll talk about the potassium and other electrolytes. So potassium-related issues are a common exam and real-life pitfall, and the reason why we concentrate on the potassium is because insulin drives the potassium into the cells, and that can risk arrhythmias in the patient. And our management will depend on the level of potassium that we'll see. So if the potassium is less than 3.5, we will do a senior review and we'll replace the potassium levels before administering the insulin. If the potassium levels are between 3.5 to 5.5, we'll add potassium chloride to the fluids that we administer. And if the potassium levels are over 5.5, we will give no potassium initially, as they are far too high. And these are just rough values that you should know off the top of your head. And other things that we can do to take note of the potassium levels is to look at their symptoms to deem if the patient is in either hypokalemia or hyperkalemia. So low potassium levels can cause muscle weakness, cramps, and fatigue. Patients may also have palpitations or arrhythmias, and you'll note ECG changes like flattened T waves or U waves. And constipation is common in these patients, and severe cases can cause paralysis. But with regards to high potassium, you can have muscle weakness, tingling, paralysis, and it often affects the heart, causing palpitations and dangerous arrhythmias, with ECG changes like peak T waves or wide QRS pattern. And a lot of patients that you'll see won't have any symptoms until the potassium levels are very high. Then in terms of monitoring, I've split it up into the initial hourly monitoring that you'll do within the first hour, then how you'll monitor the patient the next 2 to 4 hourly period of time, and then how you deem that the DKA episode has resolved. So hourly, we'll monitor the capillary glucose, ketones, and vital signs. Every 2 to 4 hours, we'll do either VBG or Usinase to assess the potassium levels, metabolic acidosis, for example. And in terms of resolution, we just need to see if the 3 markers of DKA are resolved. So if the ketone levels are less than 0.6 millimoles per liter, the pH is over 7.3, and the bicarbonate levels are over 15. And in terms of when to escalate DKA, we have a very low threshold for ICU involvement. And just because a patient has got into a worse condition, it doesn't mean that your management is bad. It sometimes does happen, even if we have done all these steps early on in terms of escalation. And these scenarios when to escalate DKA would include a pH less than 7.1, hypokalemia, a patient producing a reduced GCS, so either they're very lethargic, comatose, hypertension despite the fluid boluses you've been administering, if the patient is pregnant, or if the patient's had recurrent or refractory DKA episodes. Then now we'll move on to HHS. It's a similar presenting condition and common endocrinological emergency. And its key features are the severe hypoglycemia, the very high osmolality, and the differences between HHS and DKA is that you'll see little or no ketosis and no significant acidosis. And hyperosmolar hypoglycemic state occurs due to severe relative insulin deficiency. It's usually in people with type 2 diabetes. There's enough insulin to suppress ketone production, but not enough to allow the glucose uptake, and that leads to the very high hypoglycemia. And excess glucose causes marked osmotic diuresis, so that leads to severe dehydration and electrolyte loss. And progressive dehydration leads to the raised serum osmolality, and that causes the neurological symptoms such as confusion, reduced consciousness. And because the ketone production is suppressed, you will not see that ketoacidosis that you will see in DKA. And as I've said on the slide, it's typically in type 2 diabetics and older patients. And I just have a comparison table that I thought would be quite nice to summarize the differences between DKA and HHS. The main differences, as I've said earlier, are the fact that you have the minimal ketones in HHS, the pH range is normal in HHS, and it's a very gradual onset in terms of progression in symptoms in HHS versus DKA. I'll give about a minute or so just so everyone can read the slide. Okay, in terms of management, we will give the fluids at a slower rate than in the scenarios of DKA. And the reason why is because if the glucose levels drop too fast, it can cause cerebral edema. And HHS management is rather senior-led. So your role in this scenario would be to recognize early that the patient has HHS and to administer fluids at the correct rate. And the reason why I will emphasize that glucose levels have to be gradually decreased is because if they rapidly drop, it can cause a sudden drop in the serum osmolality. And this is before the brain can adapt to this change. And that leads to water shifting into the brain cells and risks cerebral edema. And then, although it's uncommon in adults, it can be life-threatening, and the patient could present with headache, confusion, reduced GCS or seizures. And that's why we used a fixed-rate insulin infusion rather than with cautious fluid replacement and close monitoring, rather than rapidly trying to get the glucose levels back to normal. And in this case, we'd also provide VTE prophylaxis as there's a high risk of thrombosis. And I will just recap the fluid levels again. So in terms of initial resuscitation, we'll give the 0.9% sodium chloride at a rate of 1 liter per hour. And then after that initial period, we will give either 0.9% or 0.45% sodium chloride at a slower rate of 250 to 500 mils per hour. And the reason why I've wrote down you can give 0.45% sodium chloride is because if the corrected sodium levels are high at that point, you will do that to prevent hypernatremia. And a way that I like to remember the ongoing replacement rates being decreased is, for example, in those who are elderly with renal impairment or cardiac diseases, we tend to give small amounts, boluses of 250 to 500 mils per hour in their fluid replacement. And I've just done a few case studies in between just to see if everyone's understood what's been taught and to see if it's been good what's been explained. So I'll give you guys a minute to read through. I'll also read it out loud. So we have a 78-year-old woman. She's a type 2 diabetic. She's presented with a 3-day history of confusion and reduced oral intake. In terms of her OBS, we have glucose 42 millimoles per liter, ketones 0.4 millimoles per liter, a pH of 7.38, serum osmolality 335 milliosmoles per kilogram. And our 3 questions are, does this patient have DKA or HHS? Why is this diagnosis, whichever one it is, easy to miss? And what is the most important initial treatment? And I'll give a minute for you guys to have a think. If you feel comfortable, drop it in the chat. If not, just think about it in your head. Okay, so I've given you guys some time to think. Let's see what the answers are. So the first answer is HHS. And the reason why is because of the history that's included in the case study notes of the 3-day, so quite a long history of the confusion and reduced oral intake, and the fact she's a type 2 diabetic. And the reason why this diagnosis is easy to miss in real life is because of the subtle presentation of the gradual confusion and the progressively worsening oral intake. And the most important initial treatment would be fluids with the slow correction rate that we've mentioned. And in terms of how you would exactly do it, you can look up your trust guidelines and see how it is depending on that. From place to place, it will vary. Okay, now we have another case study. So we have a 22-year-old man. He's known type 1 diabetic. He presented with vomiting, abdominal pain, and he missed his insulin for 2 days. In terms of his OBS, his heart rate is 118, blood pressure 102/64, rest rate 28, and oxygen saturation 98% in room air. His capillary glucose was 24 millimoles per liter, and his capillary ketones 5.2 millimoles per liter. What's your immediate assessment approach? Does this meet the criteria for DKA? And what are your first 3 management steps? I'll give you guys another minute to have a think through. If you want, drop it in the chat. Otherwise, I'll do that. Okay, now let's go with the next question. So in terms of our immediate approach, we'll do, as always, the ABCDE and early glucose and ketone testing. And does this patient meet the criteria of DKA? Yes, as they have all the 3 parameters we've discussed earlier. And what are our 3 management steps initially? Fluids, the fixed rate insulin infusion, and the bloods. Okay, so back to me explaining again. So adrenal crisis is an acute cortical deficiency, and it's a life-threatening emergency. And the typical causes that you should recognize or keep in the back of your head include known Addison's disease, chronic steroid use with sudden withdrawal, or acute illness or surgery. And adrenal crisis is often missed, and many patients that have this problem, they carry a steroid card or an emergency injection kit with them to avoid this. And in terms of recognizing adrenal crises, the common symptoms that you might see would include hypertension, shock, vomiting, abdominal pain, severe fatigue, confusion, hypoglycemia, hyponatremia, or hyperkalemia. And if you see a patient with hypertension that is not resolving even with the fluid administration, you should have in the back of your mind adrenal crises. And here we have in the bottom corner an example of the steroid emergency card that I've mentioned that some patients might have. And these sick day rules are a key way of preventing an adrenal crisis happening in the first place. And patients who are on long-term steroids, they should either double the oral steroid dose during the periods of illness, for example, when they have a cold or infection, maintain their fluid intake, encourage them to drink lots of fluids, to seek medical help if they're vomiting and recognize the symptoms of an adrenal crisis early on, and to also carry their steroid card or their medical alert bracelet. And while you're on the ward, you should reinforce these sick day rules in a patient by recognizing that they need their steroid dose doubled, for example, or maybe that they need more fluids than usual, potentially administered IV if they're not orally tolerating it. And also when discharging a patient with these presentations, to make sure to adjust the doses on the discharges and during ward reviews itself. And in terms of treating adrenal crises, do not delay the treatment of this for further testing to find out what's wrong with the patient specifically. Give the patient IV hydrocortisone 100 milligrams stat. Then after that, we can give 50 milligrams IV in a 6-hourly period, or either a 200 milligram infusion over a period of 24 hours. In terms of fluids, as always, 0.9% sodium chloride, and to then treat the precipitating cause once you've fixed it. So I have to emphasize, give the hydrocortisone first and then investigate later. And you should do that even if you're uncertain of the diagnosis, as delaying causes further problems, and we want to fix this as soon as possible. Okay, I have another case study. So we have a 45-year-old woman. She's got known Addison's disease. She presented with vomiting and diarrhea, and she's unable to keep her tablets down. In terms of her OBS, her blood pressure was 88/54, heart rate 112, glucose 3.2 millimoles per liter, sodium was 126 millimoles per liter, potassium 5.9 millimoles per liter. What's the likely diagnosis? What is the single most important immediate treatment? And would you wait for the cortisol results? So I'll give you guys another minute or so to think. Okay, let's get started. So, the likely diagnosis is an adrenal crisis, and the reason why is the patient is known to have Addison's disease and she presented with vomiting and diarrhea. And the single most important treatment is, of course, the IV hydrocortisone. And would we wait for the cortisol results? No. We would give it first and then see and try to figure out the underlying cause. Then we'll move on to our final condition that we'll discuss. So this is hypoglycemia. It's a common inpatient emergency and it can lead to seizures, coma, death, and it's often iatrogenic through the medications given on the ward or what the patient takes themselves. And at-risk groups would include insulin, sulfonylureas, people with renal impairment or with a poor oral intake. And hypoglycemia tends to be a patient safety issue and is often preventable with the right management and steps. So hypoglycemia is a blood glucose level less than 4 millimoles per liter. I put that in bold as that's a number that you should remember. And the symptoms include sweating, tremor, palpitations, confusion, drowsiness, seizures, and reduced GCS. And these symptoms may be absent in patients with recurrent hypoglycemia. So in those patients, we would determine if they have hypoglycemia based on their glucose levels, which we'll do via regular checks. And in terms of the management of hypoglycemia, it would depend on if the patient is conscious and able to swallow versus if they're unconscious and unable to swallow. So if the patient is conscious and they're able to swallow, we'll give them 15 to 20 grams of a fast-acting carbohydrate, and we'll recheck the glucose after 10 to 15 minutes to see if that has helped and do further management based off that. But if the patient's unconscious or unable to swallow, we'll give either an IV 10% glucose or we'll give intramuscular glucagon if we can't get IV access. And in terms of the management, you can look at the local trust hypoglycemia guidelines, and it's important to always recheck the glucose after you've administered that initial dose of either the fast-acting carb or the IV or glucose or the IM glucagon. And it's always good to give the patient longer acting carbs afterwards because that will help with the hypoglycemia. And in terms of hypoglycemia escalation and prevention, we should identify the cause to prevent this happening again, to adjust any insulin or medication suitably. For example, the insulin dose may be too high, or they're taking a medication that precipitates hypoglycemia episodes. And we should document this clearly that this episode has happened and what you've done in terms of your management, how the patient clinically is currently, and to include it in the handover. So whenever you finish your shift, the other doctor who's taken over from you knows what to do. And if the patient's having recurrent episodes, to escalate it to a senior because they may need further investigation of what to do. And it's important to prevent recurrences because, as I've mentioned earlier, there's lots of effects that can happen due to hypoglycemia, and it's better to prevent it than to let it go on. As later on, recurrent episodes, you might not even notice it because they become asymptomatic. And in terms of my key take-home messages, I would say to check glucose early in any patient who's unwell, because that's an easy test to do, and you get the result pretty much straight away. When you're managing DKA or HHS, to give fluids first in terms of the management. And if you suspect that a patient has adrenal crises, never delay giving IV hydrocortisone. And if a patient has hypoglycemia, treat it immediately, then investigate why the patient's having these episodes. And if you're ever having any doubt, as always, escalate to a senior early on. Nobody will expect you to do it on your own. And I guess my final take-home message is that if you spot something early on, prompt action does lead to good outcomes, and you can easily, if you take some time, recognize these signs. And always, if you're unsure, take a look at the guidelines of your trust and ask for help early on. No one will be angry or upset at you if you ask for it early on rather than trying to do something on your own. And here are some social media platforms that we have on Mind the Bleep aside from YouTube, and some exclusive discount codes you guys can use to get some money off when you're having to buy some question bank packs. Give you guys a minute or so to take a look. And then the final part is please fill out the feedback form by scanning. We really appreciate it, and it would help us a lot in terms of deciding what to do with our future webinars. Thank you for listening. And I'll also hang back a few minutes if anyone has any questions they want to answer.